Going. All right, hello all, welcome to the next iteration of the intro for psychedelic care for basically end-of-life issues, end-of-life care. So I'm going to go ahead and start to share my presentation and we'll get going. I would ask if you could to refrain from using the chat for now, and then I'll open it up for questions at the end, and I prefer to take hand raises then because it's so much easier for me to manage and to see who's asking a question and to get to them. So again, and try and leave plenty of time to ask your questions. But here we go. Just a little bit about me, hopefully. Okay, so I started off, I think, this journey in particular when I owned a home healthcare agency, some 250 client home healthcare agency in Sarasota, Florida. And it really got me thinking about taking care of and caring about individuals toward the end of life. And so when I started to study psychedelics, oh gosh, over 3.5 years ago already, I just gravitated towards that research, which is why, yeah, I just absolutely love delving into the research that there is and the research that's coming up in it. And a lot of it earlier on, or I say earlier on in the modern era of psychedelics, it came out of Johns Hopkins and NYU and UCLA. Before that, in the 50s and 60s, there was a lot more research using LSD in patients with cancer. So anyway, I just gravitated towards that. And when I did some work for a psilocybin retreat in Jamaica, and we were doing two things, and one we're successful at, and that is training anybody who's interested in an end-of-life role and with a psilocybin experiential. So to go down to Jamaica, 6 days, 5 nights for 2 psilocybin journeys and modules around the topics of death and dying. However, I couldn't get anybody, as I started to say earlier, to go down to Jamaica who had a life-threatening illness. It just seemed to be too risky for them. So that's when I decided I have to bring the psychedelics to where the individuals are. I did graduate from the 12-month Psychedelics Today program, which I strongly recommend. Very comprehensive program, taught me a lot. And then I'm also certified through 3 Deepak Chopra programs. So you'll see some of that reflected later on in the presentation. So we'll cover a bit about the psychedelics, the research, health considerations. As I'm not a physician or medical person, this will be really high level, but I think it hits sort of the high points of what you need to know. And then we'll delve into what does it mean to work with the psychedelics for people toward the end of life. And yes, I've got tons of stories, so hopefully we'll get to most, if not all of them, and then we'll open it up for questions. So today we're going to focus on psilocybin, MDMA, and ketamine. Psilocybin because it's the most widely researched and continues to be so. MDMA because it's also been researched and is for PTSD. There is one ongoing study with MDMA for couples where one of the couples has a cancer diagnosis. So really great to see, because MDMA, before it was rescheduled into as a controlled substance, it was used in psychotherapy for couples. And then ketamine because it is widely available and it is legal, and also been shown to help people toward the end of life. And as I started out to say earlier, if you weren't on the call already, so end-of-life psychedelic care to me means anybody who is beginning to suffer existential or psychological distress, primarily due to a diagnosis that's life-threatening, life-limiting, or terminal, or at least thought to be terminal. So to talk about the psychedelics, then there are some really key similarities. Of course, all of them create an altered state of consciousness. I don't want to get into a controversy about, is ketamine a psychedelic or not? It's clearly not a classic psychedelic like LSD or psilocybin, but basically we all tend to put it into the same category of being a psychedelic, as well as with MDMA. They all across the board can reduce anxiety, depression, PTSD, and many other types of mental distress, as well as other things like migraines and chronic pain. The big thing, of course, and we'll be highlighting this as we go through, is that they all increase neuroplasticity. And that is the real benefit of psychedelics. It helps us learn new thought and behavior patterns and a whole host of other things. And then it probes deep into the psyche, right? These journeys are not always pleasant. Many of them are, many of them can be, many of them can be mitigated with the proper preparation. But nonetheless, they're going to uncover things that maybe you had hoped would stay covered for the duration of your life. But if we look at some of the key differences, as I said, psilocybin is a classical psychedelic. It works primarily on the serotonergic system. And one of the big things about it, and ketamine for that reason, is that it quiets the default mode network. The default mode network, or DMN, comprises 3 different regions in the brain. And it is that region involving with learning and memory, but also when we're not immersed in a task, or in the case, say, listening to a presentation like right now, then that's the regions of the brain that give rise to worry, anxiety, worrying about the future, worrying about the past, negative looping thoughts. And so for those of us with depression or anxiety, the DMN is overactive, and to be able to quiet it is huge in our ability to then get on top of some of what is causing the depression and anxiety, and then helping to resolve it. Psilocybin is considered one of the gentlest on the body, as I mentioned a little before we started, much better than, say, ayahuasca or ibogaine. Others are considered gentle as well, but psilocybin has an ability, I would say, over MDMA to be used closer to the end of one's life. MDMA probably more toward when the diagnosis was made. It does have a higher potential for mystical experience over the other 2 we're talking about today, and it can bring issues front and center. When we get to talk about the client stories, what you'll hear is that they very often confronted their cancer. They talked with their cancer. They came to terms with their cancer. So it brings everything front and center. A 4 to 6 hour journey duration, and no known lethal dose, and non-addictive. This is sort of an obligatory slide that everybody shows when they're doing a psilocybin presentation. And this is just such a cool graphic that shows how, even though psilocybin is quieting this DMN, it's also exploding the communication pathways. So when you look at the graphic, the picture on the left, that is very typical of what our brain regions look like. The communication pathways stay within, say, the visual or auditory cortex region. And then on psilocybin, you can see it explodes. This gives rise to the synesthesia, the hallucinogenic effects, the flexibility and the creativity that lasts long after the actual psilocybin journey. So that's really key also to the effect that psilocybin has on the brain. Now, when we talk about the research, this is just 3 of the studies. And as I mentioned, sort of the granddaddies of the modern era are Johns Hopkins and NYU. So those lighter blue bars represent the significant reduction in anxiety in 2 of these studies. So in Johns Hopkins, fully 83% of the participants reported a reduction in anxiety. In the NYU study, 58%. There were 2 doses administered in the Johns Hopkins study, 1 dose in the NYU study. However, the reductions in anxiety, those depression bars, the reduction in depression was similar. So 78% in Johns Hopkins and 83% in the NYU study. Now we fast forward to last year, and Sunstone Therapies, which is a research facility in Rockville, Maryland, and one of the research sites several times in conjunction with Johns Hopkins, published the results last year. And the thing that they showed, which is so totally cool, they only looked at depression. So that red bar showed 80% of the participants reporting a significant reduction in depression. However, what is so totally cool is that 18 months, and this is after a single dose with associated psychotherapy, after 18 months, 67% of the participants are still reporting a significant reduction. And then, not on this slide, but 57% reporting scores that showed them to be in remission. So phenomenal. I mean, absolutely phenomenal. I think that the psilocybin trials as it relates to cancer patients are some of the best that you'll find in any of the psilocybin studies. And I think that has to do with the mystical experience. And hopefully we have time to come back to that. And so, yes, for any of you people who really are interested in the research, you'll get this slide. You'll see that these are 1, 2, 3, 4, 5, 6, 7, 8, 9, 9 studies that I know about that are either in the planning phases or are ongoing and are either recruiting or will be recruiting. And so if you go to clinicaltrials.gov and you put these keyword searches in, you will find a lot more information about these different studies. And one of the things you'll see earlier on, Johns Hopkins, UCLA as well, NYU, all looked at depression and anxiety scores. Well, as the researchers really began to think of what is it that becomes really difficult for an individual faced with a life-threatening or terminal diagnosis, they were thinking about things like demoralization and existential distress. And so now you'll see some of the studies looking at that. You'll also see some of the studies looking at chronic pain. You see there, Emory University is, I think that's in planning phases. I do not think that is underway yet. And then you've got Johns Hopkins looking specifically at depression in patients with mild cognitive impairment or early Alzheimer's disease. Now let's switch over to MDMA. MDMA is an entirely different beast in a way. It is considered an empathogen. It's a heart opener. Some studies have shown it's because there's an increase in oxytocin, although other researchers will dispute that's the reason. Nonetheless, it is known as a heart opener. It enables not just self-compassion, but other compassion, which is why it made such a great molecule for couples therapy back, like as I said, before it was put into Schedule 1. It's different than psilocybin, clearly, because it increases the activity in the prefrontal cortex while decreasing activity in the amygdala. So this is why Rick Doblin and MAPS set out to use MDMA for PTSD, because it allows trauma victims to revisit their trauma in a way that they can dissociate from it in terms of fear, and it allows a trained psychotherapist to help them work through that trauma and in so doing heal it. Mystical experiences then are rare because you're much more conscious of memories as opposed to a major hallucinogenic journey. Journeys can be more like 6, sometimes 8, depending here on dose. In this case, because it's dumping a surge of serotonin into the system, as well as to a lesser degree, dopamine and norepinephrine, there's a risk of serotonin toxicity at very high doses. You do not see that in any of the clinical studies. So when administered in a safe environment, in a safe and supportive environment, there is no concern about MDMA and toxicity. So there actually was one study that MAPS did. I think it came out in the 2000 teens somewhere. But it was a very small study, and it was done at UCSF, and it was looking at anxiety in patients with life-threatening illnesses. it did not show a statistical significant reduction in anxiety. However, there were 19 people in that study, and there was one tremendous outlier that kind of threw the results out of whack. But Sunstone Therapies is conducting this study, and the last time I checked, they were actually still recruiting for it. So one of the dyads has to have cancer, and then the other individual can be their spouse, their significant other, their adult child, whomever. And they go through the exact same standard MAPS protocol, which is 3 MDMA sessions, preceded and then followed by psychotherapy. So you see what Kurt Niemes, he wrote an article. So there is no research yet published on this because it's still ongoing, but you'll see what he wrote there. I mean, it totally shifted, his relationship with death. Also not here, but the article had said that it totally shifted and improved the relationship with his spouse as well. Ketamine, yet another beast. This psychedelic is termed a dissociative anesthetic. It was approved by the FDA in 1970 as an anesthetic. It was widely used on the Vietnam battlefield because it's both an analgesic and a sedative. And what the doctors found was that those soldiers who had been administered ketamine had lesser incidence of depression, of anxiety, and PTSD. So it wasn't until about the 90s that ketamine was used off-label, and several studies were published about this and used off-label in a wide variety of mental distress. Extraordinarily good for suicidal ideation because that fourth bullet there, fast acting but short lasting, is really important. It's fast acting for a number of reasons of the way that the glutamate works on the system, especially the downstream mechanisms. And it has the ability, unlike psilocybin or MDMA, to actually increase the volume of the dendritic spine. So we won't go into that so much, as it has an ability to also mimic BDNF, the brain-derived neurotropic factor, so huge in neuroplasticity. And so it makes it really great because it acts really fast. So for somebody with suicidal ideation or depression, for that matter, it can reduce it within 24, sometimes 48 hours, but many times within 24 hours. However, it is short lasting, again, because of the way the glutamate downstream mechanism works on the brain, works on the system. So typically for people with severe depression or anxiety, or somebody like me who had high anxiety and negative looping thoughts, we all undergo loading doses, typically 6 loading doses over a 2 or 3 week period of time to really get the ketamine into the system and to begin to work and to prolong the duration of the therapeutic benefit. It's incredibly effective to treat chronic pain. So people with fibromyalgia, with migraines, with neuropathy, with trigeminal neuralgia, with complex regional pain syndrome, CRPS, are helped greatly through ketamine at much higher doses than you would see for a patient undergoing mental illness, mental health types of treatment. Different than psilocybin, it can put you into an observer mode. So what it does is it gives you that ability to more objectively look at your issues and hence deal with them. It's famous for this die before you die, because as a dissociative and your mind separates from your body, you have a sense of an ego death. You do on psilocybin as well, but not necessarily in the same way. But practitioners who use ketamine speak about this quite often. And so as you practice dying before you die and you lose your fear of it, you're able to overcome then anxiety around the fear of dying. That journey duration is much shorter, so it's a great substance to use, I'll say, anywhere along the continuum of an individual who has just been diagnosed to really being close to the end of life. And I've got some stories about those as well. Now, as many of you no doubt know, this can be lethal in very high doses, and it's potentially addictive. So when it's not under the care of a prescriber and used recreationally, it can be addictive. And as we all saw with Matthew Perry, it can actually be fatal when you're in a hot tub. Okay, so I want to delve a little bit more into ketamine because it is so widely available and it comes in so many different forms. So ketamine through infusions, and those numbers in the parentheses are what we call bioavailability. So how much of the ketamine actually gets into your system. So infusions you typically only see administered in clinic. And this is for folks typically for more severe mental distress and or chronic pain. Intramuscular injection, widely used, as well as subcutaneous, although subcutaneous is not used as often as intramuscular. And that is primarily used in clinic. However, I've been talking to many hospice and palliative care physicians who are now going into the homes of their patients, and administering IM with a great degree of success. That also used for severe mental distress and or chronic pain. And then all of these then have the ability to reduce, let's call it existential distress as well. Then there's the nasal spray. So nasal spray comes in two forms. FDA approved a form of ketamine called S-ketamine, Spravato, that is administered only in approved clinics under the direction of FDA, and it includes, you have to have a prescription for an SSRI as part of this treatment. And it's been shown to be, FDA approved it for treatment-resistant depression and major depression disorder with suicidal ideation. So the good news about Spravato is it can be reimbursed if your insurance supports it. So I would always say, have at it with Spravato first, because infusions and injections you pay out of pocket unless it's for chronic pain. However, Spravato has been shown to be less efficacious than IV. I don't think it's been pitted against IM in a study, but it has been comparable studies have been done with infusions. So then there's also compounded nasal spray, used in the home, typically to prolong the therapeutic benefit, especially for patients with chronic pain. Very successful in doing that. Really is helpful for anybody who has to pay for infusions or injections out of pocket. And then we have the whole at-home market. Typically, these are used at home. There also can be used in clinic for psychotherapists and their clients who want to just sort of open themselves up to a more deeply probing psychotherapeutic session, I'll call it. So, but they're used at home a lot to extend duration of pain and mental health. And I say here oral lozenges and tablets, but they actually frequently are used rectally. Really important for a palliative or hospice care patient who maybe cannot hold a sublingual lozenge in their mouth, and you typically have to hold it for about 15 or 20 minutes. And then some people choose to swallow, some people choose to not swallow, but some patients are not able to do it. And I'm really looking forward to, it's anticipated that FDA will approve a dermal patch this year, actually, which would be great for palliative and hospice care patients to access ketamine. Just a couple of studies here, and I'm not going to go over these too much because you basically can see that with the ketamine, there's pretty significant reduction in depression. This is out of University of Toronto. 72% of the patients reported significant reduction. 47% were in remission. There was a great study. This one on the right was a very small study, but it was done with patients in hospice It was oral ketamine delivered over a 28-day period of time, and every single one of the patients that lived, unfortunately, these were hospice patients, then all showed significant reductions in both anxiety and depression. So here's a couple of other studies that, if you're interested, you can definitely take a look at. The links are all there. And ones that are either underway or coming up are all really interesting as well, because they're looking at things like reducing dyskinesia. PharmaTher is the same company that has developed a dermal patch, but they're looking at reducing dyskinesia that is induced by levodopa in Parkinson's patients. And the Michael J. Fox Foundation donated $2 million to Yale to look at depression in Parkinson's patients. Now, typically, not just for ketamine, but for psilocybin, people always ask about the ability to either not cure, not prevent, but maybe ameliorate neurodegenerative diseases. And, the jury is still out on that. Certainly, there are reasons why it could theoretically help because of its neuroplasticity properties, because of its anti-inflammatory properties, but I would say not been proven yet. So the summary of the differences, I would say psilocybin is the most mystical. And again, one of the reasons why I think the psilocybin studies have just shown such tremendous outcomes. People toward the end of life, I find, are much more open to the other side, whatever it is you want to call it. There's this beautiful book called The Next Place by Warren Hansen, who speaks of this next place with awe and wonder, and one we should look forward to. And what psilocybin can do is pretty much put you there. So pretty much also why I feel it's probably the best molecule for this, at least of the three that we're talking about right now. As I said, it can bring issues front and center. Ketamine, as I've said, puts you in observer mode. It treats chronic pain. And MDMA, because it's that heart opener, it can really deepen or repair relationships. It can provide self-compassion for individuals that really could use to forgive themselves, as they look towards their mortality, going, I can't forgive myself for this or for that. MDMA is tremendous. And again, for deepening or repairing relationships, it's really great. I would also say, though, typically MDMA would be used when the person is, like I say, healthier, because as you all know, the MA there is methylamphetamine, a little harder on the heart. Psilocybin, much better, closer toward the end of life. And then ketamine, yes, definitely. So contraindications, just the general ones across the board apply obviously to anybody in palliative or hospice care. So whether that's uncontrolled hypertension, severe heart disease, or severe asthma. Patients undergoing chemotherapy, and I've got a story about that. So basically, you look at that on a case-by-case basis and can schedule psychedelic journeys around, say, chemotherapy. Standard exclusions in clinical trials have always been schizophrenia, bipolar disorder, and borderline personality disorder. However, it's really great. I think that people are challenging that and beginning to look at the potential for psychedelics to also help these illnesses. And then ketamine, because of the way it works on the liver and bladder, individuals with severe liver and bladder disorders can be ruled out. Unfortunately, ketamine gives rise many times to painful cystitis. And so I closely follow, there's a ketamine Facebook group, and in their files, they have a bladder protocol for anybody undergoing ketamine. This is especially true for anybody undergoing a pain protocol, because the doses are so much higher and quite often a lot more frequent. Drug interactions. On the psilocybin side, we've known for a while that the SSRIs and SNRIs can blunt the effects. And what's really cool as people move people move beyond just the research and into real world scenarios, is that they're really finding that, yes, it can blunt the subjective effects, but that doesn't necessarily mean, people made a correlation between that it must be blunting the antidepressant effects, and that's not necessarily what people are finding. So it's really interesting. There's still, and I run into this all the time with retreat operators who don't want to support any participant with an SSRI or SNRIs, or actually some of the other antidepressants as well. And that's, I know, because of liability reasons, but point in fact, it's quite safe. I would just say contact people like Dr. Ben Malcolm, who can help with any drug interactions and can consult for you or your clients or patients on that. We know that lithium, significantly higher risk for seizures. But you see on the ketamine side, it's totally flipped around. So lithium and SSRIs can actually enhance the effectiveness of the medicine. Benzos, in the case of psilocybin, can stop the trip. Benzos can also reduce the effectiveness of ketamine, but many times they're used in an infusion to calm an overly anxious or panicked patient. So it doesn't necessarily reduce the effectiveness totally. Typically, a patient is told not to take their benzo that morning if they can avoid it. Same with lamotrigine, because it works on the same NMDA receptor, and I'm on lamotrigine. That is potentially why I needed 2 milligrams per kilogram, a fairly significant dose to get therapeutic benefit. So nonetheless, ketamine can work, it's just can reduce effectiveness. Similarly, St. John's wort and other supplements, because of its action on the liver. So you have to look at your supplement list as well. And then MDMA, SSRIs and SNRIs can greatly reduce effectiveness. So this is definitely a medicine that people have said individuals should come off of before undergoing MDMA, or at least for therapeutic benefit under MDMA. I know that when MAPS was studying this in relation to PTSD, participants who maybe were off of the SSRIs for 2 weeks did not see great therapeutic benefit until after the third MDMA dose. Wellbutrin, on the other hand, can greatly increase the effects, and it can be dangerous at certain points. And so typically one can reduce the dose of MDMA for patients on Wellbutrin. Now the MAOIs, because they can also not flood, but they allow for the excess serotonin to be put back into the system. There's a bigger risk for serotonin toxicity with MDMA than there is with psilocybin, for example. All right, now let's shift gears. Working with psychedelics toward the end of life. We know that there's several benefits. These also can be thought of as intentions. These benefits are true for a lot of people, but truly for people faced with a terminal or life-threatening diagnosis, this is probably top of mind. So to ease that anxiety and depression, to reduce that fear of dying, to reduce chronic pain, to learn to live in the present moment and bring purpose and meaning to one's life, to experience a oneness with the universe and bring a sense of awe and wonder to the next place. And, and to not just to experience a oneness with the universe, to experience what it is like to be on the other side, basically. And so we know we've got examples of people who have experienced all of this, and that is the wonder of these molecules, and why there's those of us who work so ardently in this field. When we think about people toward the end of life, their issues, we have to be sensitive, I think, to the issues that they are facing different than maybe patients or clients very early on, much earlier in their life and not confronting their mortality. So there's cultural issues around death and dying that we have to be sensitive to. Their religious beliefs, are they a believer in a vindictive God or in a loving God? Do they think they're going to hell, or do they think they're going to heaven? The family dynamics, as you can imagine, the family is going to weigh in on any loved one undergoing a psychedelic journey. It's going to be so key to engage the family when you support somebody toward the end of life. There's issues of losing control or feeling of failure, both to themselves and to their families. They're dying. They don't want to die. Their physical body is failing. They don't want it to fail. They're letting down their family. They may have been the matriarch or the patriarch. So what's going to happen to their family? And then, as I mentioned before, forgiveness. To forgive oneself, huge. To forgive others, really great before one passes. There's so I was thinking of, intentions that I've heard of, and this by no means covers all the intentions, but it's basically, again, when I think about people toward the end of life and some of what they could go into a journey on, is to let go, to love yourself, to embrace death, to experience that next place, to forgive, fill in the blank, and to say goodbye. And it's not just saying goodbye to their loved ones, although that is part of it. It's saying goodbye to everything that they've experienced, everything that they've become attached to, whether that's material or not. And then recognizing that they're going to a place that potentially is filled with awe and wonder. And some of this is taken from, there's a great book, The Four Things That Matter, by pretty well-known palliative care physician, Dr. Ira Byock. So let's switch to preparation. Preparation, and it's the same for just about everybody, but in terms of thinking about people toward the end of life, I think there's several things to take into account. And preparation, we use this phrase preparation, and all of us who've gone through psychedelic training, it's broken into three processes: preparation, the journey, and integration. And really, this is a way of life that's so important, I think, for people to enjoy emotional, spiritual, mental well-being. So to me, the key really here is knowing thyself. For anybody undergoing a journey, I would say at this stage of life, please, please, please do it with a trained facilitator. And I would say a facilitator who has some training in end-of-life care is even better, if possible. We also talk about set and setting, and the setting is that environment in which you're going to undertake the journey. And that setting, that facilitator, is probably the most important part of your journey, because if you can't trust that person to totally let go, it's going to make a very difficult journey, or it's going to make a journey that probably isn't as beneficial as it could have been. In terms of preparation, then, for some very specific things, always review the journey, and I'll talk just a little bit about that so that the individual knows what to expect. Review their intention, and the intention can change. The intention just could be to be intentional, not even to have a very, very specific intention, but to know that you're trusting the medicine to work to help you resolve something or other. You have to decide before this period, but basically, do you want to do this solo? Do you want to do it with your family? Or does your family want to do it with you? Or do you want your family to be in the room while you're undergoing a journey? Or do you want to go to a retreat? And there's pros and cons of each of these things that you really need to think about. And everything you do has got to be what feels comfortable to you. Your facilitator might recommend something to you, but ultimately you've got to decide what makes you feel comfortable. And some of these things have to do with identifying how you handle challenges. So, for example, if what causes anxiety? Is it because you're avoiding a conflict? Do you get angry when somebody criticizes you? Do you get anxious when somebody criticizes you? Do you get angry when you think somebody else is stupid? Some of these are my issues. So trying to really get to know yourself then can really go a great way into what you learn from the psychedelic journey and what you're going to do with that psychedelic journey on the other side. So important is practicing mindfulness to self-soothe. You and the facilitator should identify a safe word. If you start to get anxious during a journey, start to panic, have that individual repeat that safe word. And this is one that both of you then select. For this community, it is so great to be able to speak with other individuals undergoing the same issues, meaning, of course, that they're faced with a terminal or life-threatening illness. And to the extent that we can help our clients do that, I would say, yeah, let's do that. Best is in person, but we can do that online as well. We know that it's important to select that playlist. Those journeys just in conjunction with music, it always amazes me how they all just sort of weave in together. And then when I say engage family, whether or not they're going to participate in the journey or not, this is separate. The family has to know what's going to happen to their loved one. The family has to understand that they may come out on the other side, a different person wanting to take back control of some of the decisions. And this happens a lot. Families think that they know best for your client or patient, and they don't always, obviously. And it's up to us to really honor and advocate for our client or patient. Some mindful techniques. I've done a whole class on this, and we don't have time, obviously, to do this today, but there's so many things that can be done for self-soothing, for resourcing, for whatever you want to call it. Some very simple breathing exercises, selecting a mantra. And I would always say, try out different breathing exercises with your client. What works for you doesn't always work for them. My most favorite example is I think it's a 4-7-8 breathing exercise where you inhale for 4 counts, you hold for 7 counts, you exhale for 8 counts. And I have had really experienced meditating instructors do this. And it's like, some of our clients cannot exhale for 8 counts, and you get all like caught up in like, this is not doing anything for me, and it's not working. So try out different techniques with your client, get them to select what works, and practice that several times before the journey. Similarly with a mantra that works for you is not necessarily going to work for them. Somatic techniques, a whole range of somatic techniques that I wish we had time to talk about. But this is another beauty of the psychedelics that will be so helpful in integration, where you can bring that feeling into the body again. Psychedelics helps us embody those feelings. We can resource them, bring them back. And I like to call it or think of it as resource to transcend it. And I do this based on an amazing journey that I had once. Supportive touch, obviously we can talk about that for a very long time. The most important thing here is it's what the client wants, and you gain consent each and every single time you do it. But there's some really, really, really safe and lovely things. And the other thing I think about for people toward the end of life, they're poked and they're prodded people don't hug them as often as they need to be hugged. And this is just such an important time to offer supportive touch. You know, the forearms, the feet, the shins, massage lotion into their hands, their shins, their forearms. It's just so beautiful. One of the things too, is you would imagine, people toward the end of life, they may do all of these things lying down, they may do these things sitting in a chair. And then for those who are practiced, you know, to do certain energy and body movement, you can do restorative yoga techniques. Now this one at the bottom, you know, the sort of child's pose, is great to practice, because it can be potentially used to self-soothe during a journey that may get a little anxious. So if your patient is able to do something like this, and you know, it's suggested or said, you know, this is something you could try out if this helps you. Sometimes it's just holding on to a pillow is really great. But nonetheless, the important thing here is to practice all these things before. If you know how to do Reiki, do Reiki. Although I heard this wonderful story where a doula was working in a hospice facility, and a hospice nurse just was like amazed at what she could do, and she would come and she would do Reiki. The doula, Mary is her name, would do Reiki on a patient, and the nurse just wondered, well, how does she do that? And so Mary just had the nurse go over and do the exact same thing to the patient. And this patient was in an active dying process. And so Mary asked the nurse, what did she see? What did she feel when she was holding her hands and feeling the energy of the patient? And she said, I saw a scroll being unscrolled, really getting long and long, longer and longer. And Mary said, yes, the patient is undergoing life review. That is one of the things that patients toward the end of life do. And this nurse could sense it, this nurse could feel it, this nurse could help, I think, send healing thoughts to the patient as well as Mary could. And Mary is a master Reiki master. Now the journey itself. So, you know, to me, it's kind of whatever goes for your client. We can't have any expectations. We know the onset for ketamine, depending on whether it's IM, infusion, a sublingual lozenge, can be 10 to 20 minutes. We know that psilocybin and MDMA can be a 30 to 45-minute journey. You know, your clients can talk or don't talk. They need to ask for support. They need to know that they can ask for support, and they need to practice, or they need to use those things that they practiced up front. I heard a great story too that I wanted to share about psilocybin, and not just the onset, but the off ramp. So as many of you would know, you know, you can do psilocybin, typically dried mushrooms. You can lemon tech it as well. You can do synthetic capsules, and you can do naturally derived psilocybin capsules. So in Canada, there's this great program through Health Canada where individuals with a severe or life-threatening illness can get approved for psilocybin therapy. And so there's a gentleman, actually I have a story on him later on as well, who tells very eloquently that he has tried all three. So he's done synthetic capsules, he's done dried mushrooms, and he's done naturally derived psilocybin in pill form. So he clearly says the synthetic takes you up higher. He uses the word, it's relentless. It's a relentless onset. The journey is about the same, and it's a relentless off ramp, and he hates it because what he loves about the naturally derived psilocybin is it brings him gently up and it brings him gently down, and he feels he can be in this liminal space longer. He can come out of and remember more of his journey as he comes off of it. So it's just something to keep in mind. I think all of us here would probably be more fans of natural anyway, but clearly there is a distinction that not everybody knows about, because I've heard scientific researchers say that there's no difference because they're not looking for this. They're looking at the brain during the journey. They're not looking at the onset and the off ramp. All right, so the integration. So this is where I think the fun begins. And this is where neuroplasticity just really, really, really comes into play and should be leveraged the heck out of. So yes, review your insights. Sometimes you don't even have insights. Doesn't really matter. All that matters is you've gotten to learn to know yourself, to go, oh yeah, I'm afraid to confront, Aunt Sally for that thing she did to me 20 years ago. All right, let's talk about that. Let's talk about how we can shift that narrative. Or let's talk about the fact that you did this really stupid thing that you can't forgive yourself for, and you just consider yourself an idiot. Let's talk about that. Let's talk about how we can shift that narrative. Is it true you're an idiot? Is it not true you're an idiot? In internal family systems or IFS parlance, let's talk about these parts that come up. Let's honor and acknowledge these parts as being really important to you, but not the sum total of you, that we can bring in other parts. Of course, you review your intentions. Like I say, research the transcendent. I had such a beautiful journey one time where I actually existed in the universe, in my totality of sort of physical body. We in Vedic traditions, we call it physical body, sort of the personal soul or the subtle body, and then the causal body or the sort of collective soul. Well, I was there. I was so totally there. And I can pull that back into my body because that's the beauty of psychedelics. Like I said, I could embody that feeling. I can bring it back when I'm kind of feeling down about myself. All right, I don't know why select playlist is there, and again, you've got to engage the family. Now talk to them about what they see happening to their loved one after the journey, and practice all of those self-regulation techniques to cement sort of that feeling, that transcendent feeling, and to be able to come back to that when they want. Okay, some real life stories. I thank you all for hanging in there with me. Roland Griffiths. Okay, so most of you would know Roland. We wouldn't be here probably if it wasn't without Roland. He's one of the preeminent researchers from Johns Hopkins, and he passed away at the end of last year. He was diagnosed with stage 4 colon cancer the previous year. Now, he had a long meditative practice. And when he was diagnosed with the cancer, he kind of resisted using psilocybin. While he was a working scientist, he did not use psychedelics. He felt, though, between his meditative practice and the fact that he was now dealing with his mortality, that it was like a psychedelic experience. But he finally gave in, and he says, well, let me see what psilocybin has to tell me. So he actually did, and I just want to read a little bit from an interview he did with Tara Brach, which is really great. If any of you, Tara Brach is a meditation instructor, a spiritual teacher. He said, he talked, this is an example of him talking to his cancer. He says, is there something I'm not dealing with? And I asked the cancer, what are you doing here? What can you tell me about what's going on? He goes, I got nothing back. And then he said, oh, I'm going to humanize the cancer. And he said, I asked it, I really respect you. I talk about you as a blessing. I have had this astonishing sense of well-being and gratitude despite everything that's happening. And so I want to thank you. This process isn't going to kill me. This time he did get an answer, and it was, yes, you will die, but everything is absolutely perfect. There's meaning and purpose to this that goes beyond your understanding. But how you're managing that is exactly how you should manage it. So then I said, okay, I'm not ungrateful for the opportunity. How about giving me more time? And he got no answer. But what we do know is that he went on, and to the best of his ability, he was on Oprah Winfrey, right? I mean, he was written up in the New York Times. He did a number of, I think Megyn Kelly as well. He spoke with, he was trying to get the word out about the benefits of psilocybin for people toward the end of life. Thomas. Okay, so Thomas is the individual, the Canadian, who was one of the first participants in a Health Canada set of psilocybin journeys. Actually, he's undergone 7 journeys to date since 2020. This man has also undergone several surgeries and 86 rounds of chemo, my last count, which is a couple of months ago, so he could have already added to it. He had an initial prognosis of only 18 months to live. When they opened him up, his body was riddled with tumors, and that was only the first of many of his surgeries. And he attributes psilocybin not curing him, but he attributes psilocybin for helping him have the proper mindset. He talks eloquently about speaking with his cancer, and he asked the cancer sort of a similar question as Roland, what are you doing here? I don't want you here. And the cancer's response was, do you think I want to be here? I don't want to be here. He came to realize that cancer is, he calls it almost me. Cancer is as much consciousness as him, as us. And he really has come to that place of embracing that the physical body is just a physical body, and that we exist in consciousness, and where he is going is where he is right now. He's done, he will say that if he can schedule a psilocybin journey before his chemotherapy, that's what he does. 2 or 3 days before a chemo round of session, he will do psilocybin. It puts him in a much better mindset. It has anti-inflammatory properties that helps him manage the chemo better, and it helps reduce the chemo brain. So just something to think about too for any of your patients or clients that undergo chemotherapy. This story, let's see, this is Carrie Pappas, who was in the Johns Hopkins trial, and she just eloquently speaks about this embodiment that I mentioned. I just love her. All right, let me talk about a few of the ketamine patients, because this also is just so amazing to me. And then we'll open it up for questions. So Patty lives here in Sarasota. And actually, when I first started doing presentations, I only did it on psilocybin because that was the research I was reading. And then I found out that Patty, who had been diagnosed with stage 4 head and neck cancer, suffered such debilitating depression because of her fear of dying that she didn't come out of her apartment. She turned to ketamine, and she did that series of 6 loading doses that I talked about up front. And her mood started to lift after just 1 session. And she actually felt joy. That's the word that she used after 6 of those sessions. Now, for ketamine, also, what a lot of people end up doing who need it is going back for boosters. So she does go back for boosters, but she's been able to extend the time between. First, it was every 4 weeks, then 6 weeks, then 8 weeks. And she actually went out and got a job that she holds to this day. She also then was prescribed some at-home sublingual lozenges to again prolong the therapeutic benefit. However, fast forward about a year or so, and the disease took its toll. She's actually in remission, but she was suffering from painful neuropathy and trigeminal neuralgia. And for any of you who know anything about that, that is extraordinarily painful. So she returned for higher dose ketamine infusions to be able to manage her pain. And she does also have a prescription for 200 milligram lozenges to take at home. She does take them rectally because the radiation blew a hole in her jaw, which is why she has the trigeminal neuralgia. And rectally is also great for hospice, palliative care and hospice patients. Like I said, they can't hold it in their mouth, but it also bypasses the liver, which is a great thing, or very beneficial as well. So she's been able to manage her pain and manage her job. When I talked about the use of ketamine really close to the end of life, my palliative care buddy in Northern California administered 2 intramuscular injections to a gentleman who had very advanced ALS. You see, he was non-ambulatory. He had in his home an oxygen tank and a suction machine and something else that that he would potentially need, not just for, I'm not for a ketamine journey, but just because he had that in his home. And so the doctor and he and the gentleman's son had a very, very frank discussion that said, there's the potential for dying on this journey, and they both consented to it. And so you see there's sort of the protocol that the doctor followed, but the patient visualized himself running and playing, and this gave him a lot of comfort. It was like, I'm okay, my children will be okay, and he was filled with contentment. And then Dr. Fracken went back a week later, and you'll see that dosing there. He dosed a little bit higher, and he gave a booster at 15 minutes, which is typical with intramuscular. You actually break it into two injections. So he didn't talk much, but he did say it's like soul roulette. And with a great effort, he sort of brought his hands together in a posture of gratitude. And then the night before Dr. Fracken was going to go out again, he passed peacefully in his sleep. But the ketamine then brought him a degree of peace that he didn't have. It allowed him to be free of the physical constraints of his body and to give him that sense of, like I say, joy and contentment. This story I love because this woman would clearly not be with us any longer if it wasn't for ketamine. She, as you can see, is 74 years old, suffering from really severe depression and chronic pain. She just did not want to live anymore, and she began a VSED regimen, which is a voluntary stopping and eating and drinking regimen, which is considered very humane and practiced not frequently, maybe not frequently enough. But anyway, her son came to visit and obviously was very distressed, and he got her admitted to hospice. And this is one of the standard pain protocols. This was a 5-day inpatient infusion. It was so successful that she was discharged from hospice. Now, this was a woman who relied on, it was oxycodone, every single day of her life and still didn't get relief from her chronic pain. Well, now you see here, initially she went home and she was prescribed the at-home lozenges at a very low dose, and she used the oxycodone sparingly. Well, so then what the physician decided to do was prescribe methadone, which got her off of oxycodone entirely. And so 4 to 6 weeks after she was in hospice, she's now back being active in her community, doing some light gardening and regaining the weight she lost. I loved this story. This isn't about about a person toward the end of life, but I just thought it's so illustrative. As I said, I read through this ketamine Facebook group, and you'll just see all sorts of stories, all sorts of misinformation, disinformation. And people always have this concern because sometimes, because of the glutamate surge, your anxiety can spike, not just during the session, but following the session for actually several days. So you see, Mary, not her real name, has now undergone 80 sessions. And so for her first few journeys, she experienced spikes in anxiety and hour-long meltdowns afterwards. So what she began to do is exactly what we were talking about. This is such great preparation. She learned to be curious and to set a simple intention, just the word breathe. So if her mind wanders to death or she starts to panic about something, she remains curious and asks herself, what am I here to learn? And you'll hear, I mean, this is a theme. This is like similar to what Roland was kind of wanting to do. If it gets too scary, she does focus on her mantra, and she does take very deep breaths very slowly over and over again as an ability to calm her system. But this is where she maintains her agency, which is important for all of us to help our patients or clients do. So she has the agency to say, if I decide that I don't feel safe enough to do this work right now, she basically says, I'm going to agree to leave it for another time. And you see that she says twice in 80 sessions, she's actually said no to herself. And in that case, both times, that journey stopped and shifted to a beautiful image before then it evaporated. So she was really able to deal with negative or frightening feelings that may come up that, yes, need to be dealt with ultimately. This woman, as you can see, suffers from complex PTSD, but she doesn't have to deal with it when she doesn't want to deal with it. Just a little bit about me. I founded this nonprofit End of Life Psychedelic Care. As I said, one reason was to bring psychedelics to the people that need it and not make them fly to Jamaica. And it was also to provide education and a way to connect. So I just launched a members forum with a membership directory. But what was also really, really important to me was bringing end-of-life doulas and hospice chaplains into this process. No disrespect to any psychotherapist, but I can't think of a better person to hold space for a journey for somebody at any stage along the continuum of toward the end of life, but an end-of-life doula or a hospice chaplain. So I'm all about training doulas. I'm all about advocating for doulas and beginning to do some work on pilots and hopefully studies, trials with end-of-life doulas. So this is how you can reach me. I've sent out emails to you anyway, so you all know what my email is. And with that, I'm going to finally stop. And I'm like, gosh, I just thank you so much for listening. And yeah, I would love to know what questions you have. Christine. Oh, yes. Oh, no, you're just clapping. Did you want to ask a question? There was a hand raised.
No, no question. I was just clapping. Thank you so much. Yes.
Okay. Hey, Guy, good to see you.
Hi there. I don't have a question. I just wanted to express my gratitude for this beautiful presentation. It's so informative, and I'm definitely going to inquire more about getting trained to be a doula because I've been called into this work through my work with the mushroom. So I appreciate that.
Excellent. Well, it's nice to put a face with the name, and I'm
Thank you,
glad
Christine.
that you
Appreciate it.
participated. Yeah.
Yeah, thank you.
Yes, a question, David.
Yes, hi. This is wonderful. Thanks so much for it. I'm a psychiatrist and I'm going to be starting to work with a company where I'll be able to do some ketamine prescribing, and I don't have professional experience with specifically end-of-life work. A question has been in the back of my mind related to this topic, which is um, and I was wondering, this is something that comes up, which is, in the traditional dying model, with the focus on pain control and, very obviously high dose protocols for opiates in conventional palliative care, down to the end of life itself. Uh, is there ever use or discussion of use of ketamine for that itself? I'm sort of wondering about what tends to happen at the end of life itself, not just the kind of model of use of ketamine or other psychedelics in preparation, but in terms of helping someone have the greatest amount of pain control, comfort, and ideally some degree of clarity that things like methadone or other opiates are used for. And just wondering if that's something that comes up, or if there's anything you can share about that.
Oh, I could go on about that for a very long time. Yeah, so within hospice, ketamine can be used for, as you said, pain control for refractory pain, yes, very successfully. Will they use it for existential distress or anxiety and depression around the fear of dying? No. And so it's really interesting to me, and for some reason, I've just been meeting, Jeff is a good example, palliative and hospice care physicians that are interested in doing this work and going into the patient's home when needed. And it's almost having to do it outside of a hospice care protocol, right? Or a hospice protocol. And so there is a small at-home ketamine pilot that we're doing. The same physician that treated the ALS patient, Dr. Michael Fratkin. We got funding for him to treat 2 patients in Northern California. And it will be with, again, intramuscular injection, basically following the protocol that he's done in the past with success, and supporting, I don't think in this case it's chronic pain, but definitely supporting existential and anxiety and depression in patients. So what's interesting, he lives in a fairly rural community and has a really great relationship with his local hospice, regional hospice agency there. Typically, they don't refer many patients to him. So his patients come from, I mean, he runs a clinic himself. So his patients come from his own set of individuals he knows in the community, or end-of-life doulas, for example. So there's a lot of work that needs to be done. And I did a presentation a couple weeks ago it was the University of South Florida School of Aging Studies, and there are representatives from 2 hospice agencies. And you could just tell they just absolutely loved the potential for this. And you could also just tell they are eminently frustrated because it's typically not approved. So lots of work to be done. Lots of work to be done. So if you want to join forces, let's do it. In part, I know for me, education-wise, I really need to learn more about the reimbursement process. I think that's really something, the only way you're going to get around it is to figure out the reimbursement process. I mean, you can keep doing what Jeff wants to do and what Michael Fratkin is doing, and luckily he's got some community partners to actually help fund some of these at-home patients, palliative or hospice care patients. So, that may be an answer as well. But oh yeah,
Thank
you
you.
know what? You get me started. So there's studies, that show that the use of ketamine will reduce the use of opiates following surgery in palliative care patients. I mean, it's like it's all there, and yet, or for example, a hospice agency won't prescribe, or typically won't prescribe sublingual lozenges or any kind of at-home pain relief. I mean, ketamine pain relief. Okay, Denise.
Hello,
Hi there.
Christine. You have been on my radar for over a year, and this is, I think,
Yeah.
the third
That-
session that I've heard with you, and this was the most comprehensive. And I
Oh, is
just,
it?
I just love it. Thank you so much for the work that you're doing. I'm an end-of-life doula, and both past in my youth and more recently, I've been experiencing psychedelics. And the first thing that came to me as a doula is not that every person is appropriate for that kind of care, But I'm like, oh my God, this is what I've been looking for my whole life. I never knew it. I thought I was being naughty, and I was really just trying to like discover the inner me. And I just think it has so much tremendous value. And I just don't know, just kind of based on all of the things that I'm involved in, how I can fit this into a practice, even as a sitter, because I feel like I would be like such a valuable asset to anyone experiencing the depth of death compounded with the life of psychedelics. So I say all that to say I'm happy to be here, and I'm so glad to, I've been following you and learn a lot from you, and I hope to learn a lot more.
Thank you, Denise. Yeah, lovely to see you as well. I know your name. It's funny because, you know, I know a lot of your names. I see everything come across. So it's like Michelle. Hi, Michelle. No, it's pretty cool. David, the other David.
Yeah. First of all, thank you for a wonderful presentation.
Oh, you're welcome.
Yeah, I'm curious about your comment that it's not approved by a lot of hospices. I'm presently a hospice physician. I'm the medical director for a couple of agencies. I came out of mostly an emergency medicine background where we use ketamine.
Well, you got a little mixture.
But not for, pardon? We use ketamine constantly for, for pain control for various types, but we use ketamine routinely in the hospice world, either to enhance the effect of certain opiates or to treat specifically neuropathic pain, which is not well treated by most opiates. We have not been using it for the kinds of things we're talking about. But where you say it's not approved, I mean, I can imagine getting resistance from my management if it's expensive, but I can make a pretty good argument that if it's treating symptoms, that's something that's covered by hospice, by Medicare, which is most of our hospice patients are on Medicare. So I'm curious where you've seen resistance to that.
The two hospice agencies I presented to a couple weeks ago, there. Well, what we're going to do, David, is you and I are going to talk afterwards, and yeah, I want to figure it out because it typically is not done. And even, there was, I'm forgetting the a conglomerate, I'm forgetting the name, but a conglomerate went in and bought out, how this is happening, where big companies are buying out some of the smaller independent hospice agencies. And the independent actually did prescribe ketamine for exactly the purpose you're talking about. When it came in, it disallowed any use of ketamine. This was upstate New York. So there is, and potentially it's not everywhere, but I have not found it. And in talking to Michael Fracken, I think what you and I might end up doing is hopping on a call with Michael. I don't know if Jeff is still here, but because this really has to be figured out, and a game plan has to be kind of laid out.
I mean, I can tell you, I mean, our contracted hospice pharmacy, which is a hospice pharmacy here in the Philadelphia area, they stock it. And as I say, I've used it many times I've not used it for the purposes we're talking about, but I've certainly used it, as a pain control agent.
Yep. Well, we got to crack the code. That's all I can say.
Okay. Thank you.
Well, that raises a big question, actually, both David and Christine, because I've used a good bit of oral ketamine in teenagers as an adjunct for opiate pain control for end-of-life care. And what I noticed, the last one, the 18-year-old with advanced metastatic Ewing sarcoma, was that the first few days or a week that I used it, it both improved her pain management, but it also elevated her mood. She was in a much better mood, even though I wasn't using it as a psychotropic agent. I started a dose at 0.5 milligram per kilo 4 times a day orally. And ultimately, we ended up at 1 milligram per kilo 4 times a day after a few weeks, because she seemed to accommodate to it and develop some tachyphylaxis. But David, the question is, when using it for, would you be using it for the insights that one would gain through ketamine-assisted psychological work in an end-of-life patient, or are you thinking of it more in terms of adjunctive pain management?
Well, I've been using it for adjunctive pain management, but part of the reason I'm in on this is I'm trying to learn about using it for psychiatric, psychological, spiritual benefit. I know, full discussion, back in my wayward youth, I certainly used psychedelics when I was in college many years ago and didn't use them in a guided session, but found they were a tremendous benefit to me. And so when I started seeing people talking about this online, I thought this is a service that I'd like to look into, to providing our end of life patients, above and beyond the how I use it as a pain medicine.
Yeah, totally. That's my interest as well. And my experience was, I think she got the mood boost in the first few days, but then I seemed to see it disappear. But I wasn't using it with any setting or real psychological intention. And I could not get her psychotherapist to help her with the kind of processing of anything she might have experienced. So it was kind of a hit or miss experience, I think. But in the right setting, I think it's potentially very useful. Although I do like the psilocybin more in terms of a slower onset, longer effect, and slower offset.
Yeah, unfortunately not available to me in Pennsylvania without breaking the law.
Yeah, well, go to the Bay Area. East Bay's got a lot of it.
I've got plenty of friends and family out there. Yep.
Yeah.
Yeah, and that's why I meet so many people from, like you say, the East Bay. Yeah, well, we're at time, but I'm happy to, does anybody have any other questions? Yeah, Fiona. South Africa.
Hi.
Really? You're from South Africa?
Yes, I am. I'm part of this psychedelic pal care group, which put me on into this network. But thank you. I also wanted to say thank you for the great presentation. It was so informative, and I've never heard anything so educational on the topic. So I appreciate that so much. I have like weird little practical questions because I have no experience in trip counseling or anything like that. So the first question is just sort of practically, if you're counseling or you're a facilitator in a journey that's 4 to 6 hours long, are you with the patient the entire time, or do you sort of switch out and rotate while you're supporting the patient? I'm just thinking like as a surgery, sometimes you stop and you hand over to your colleague. So I'm just wondering how that works.
Yeah, first of all, oh my goodness. Okay, you're the one that told the story about the young woman with the breast cancer.
No, that
was-
wasn't me.
That
No, but
wasn't
there's
you?
another doctor who's very involved. Yeah, but I wasn't.
Okay.
I'm not affiliated with anyone who's doing anything like this.
Okay.
Sorry.
All right.
I
Yeah,
am.
that's right. She was
sorry.
from New Zealand anyway. But her name was Fee.
Right.
Okay, so what generally happens is, yes, the facilitator is there for the duration. In all the clinical studies, not all actually, but most of the clinical studies, they have 2 people. Generally speaking, one man, one woman, so that if one of the facilitators had to leave the room, then somebody would still be there. Now, I know for a fact that when this is getting done, say in Oregon, above ground, where it's legal, then yes, I know of facilitators who step out of the room to go to the bathroom themselves. But you are there for the whole journey. Now, when we say 4 to 6 hours, I mean, there's the onset that can be 30, 45 minutes, whatever. And then, you have to maintain sort of watchful observation, for the time that they're on the journey. And then, depending on how long they take to come out of it, it makes for a very long day. That's why, nobody does more than one. And in fact, many facilitators don't even like to do more than 1 or 2 a week because it takes so much out of them, right? And then not only that, they've got the preparation before, and they've got sort of the integration sessions afterwards. So that is the expectation, though. Yeah.
Okay. Thank you for answering. It seems
Well,
quite labor intensive. Yeah. Oh, it seems
Yeah.
quite that you're committing so much of your own time for that. And then I
Yeah.
just wanted to ask one more question. Because you're dealing with end of life care patients, and potentially some of these are quite frail patients or quite ill. I'm just wondering, are there physiological barriers to implementing this kind of therapy, such as would anybody die during a journey such as this, or is that something you have distress protocol for or measures put in place to prevent that from happening?
Yeah, this is I answered this question in a couple of different ways. One is every facilitator has to decide what they feel comfortable with. Are you comfortable with dealing with somebody, facilitating a journey for somebody who's pretty close to dying? If you're not, don't do it. And so there's an end-of-life doula that I've worked with several times. I mean, her podcasts with me and videos on my website, who speaks about this. And, you know, she tells the client, you know, don't die, you know, and I forget what she does. She kind of wills them back, because she's had clients that are really close to end of life, and they have in fact passed within days. It's a real thing, right? And so as I talked about Michael Fracken and the ALS patient, you know, he said, listen, and the son and the patient, he could die. You've got to be able to deal with that. Now, a gentleman with advanced stage ALS, he was like, I'm fine with that. The son was fine with that. The man was in a lot of pain, obviously. But Michael did say, all right, and they said they had the suction machine, the oxygen machine, they had something else there. And he said, but do I have your permission to use all of those things if I feel it's needed? And the patient said yes, because Michael didn't want him to pass. It's just, you know, you've got to be aware that this could happen. So I would just always say, you know, you as the facilitator get a decision in this, but to talk to the client about it, and no. And so there's also, you know, there's I would always get consults, medical consults, you know, when you feel that your client might warrant it. So, you know, in South Africa, I don't know anybody, but, you know, here in the States, there's one gentleman that I've been working with, Dr. Michael Howdy, who's a physician and a licensed facilitator in Oregon, who will do psychedelic medical consults. And then there's Ben Malcolm, who's the board certified psychiatric pharmacist, he's the spirit pharmacist, who will do consults as well. So, you know, you've got to, you know, and I will tell you, every person that I work with that I really respect has a team. This doula that I'm referring to, she has a team that she works with. So whether it's ideally it's the client's doctor, but that doesn't always happen because the client's doctor doesn't always approve. So then she makes sure that she's got on board a team of medical personnel she can rely on.
Thank you. I appreciate that.
David?
Yeah, I've got two young adults, mid-20s, who have POTS syndrome, where they've got autonomic instability, dysautonomia, etc. And given the effects of ketamine and actually psilocybin, ayahuasca are also thought to have impacts on cardiovascular status. Do you have any experience using any of these agents in patients with POTS?
No, well, I don't. I certainly don't. And I'm trying to remember, you know, my only secondhand knowledge is like what I read in that ketamine group. I mean, there is I could put you in touch if you were interested with the woman who founded the group and is up on that kind of thing. So yeah, Kimberly Jurovieski.
Okay, that'd be good, because they're both depressed and have existential distress.
I'm going to ask Michael Fracken as well, the physician out of,
Yeah, no, I'll email him if that's a good idea.
yeah. Did you sign up for the Google group?
Yeah.
Did you?
Mhm.
Cool. All right. Any other questions? Well, I thank you all for hanging with me. Extra 10 minutes as well. So hopefully I'll get to see you guys sometime in the future. And it's been a pleasure. Thank you.